Hello, everybody, and welcome to another Polestar Pilates Hour. And you might notice that I have a different background behind me. And the reason for that is that last minute, the internet services in the whole area went dead. And so we have found a new place to hang our hat for the day. And they've been very gracious, and it's called the Perch. So I'm going to put a little plug out there for the Perch. Thank you, Perch, for coming through for us, giving us a beautiful space to record and to be present with you today as we talk about the thoracic, neck, and shoulders of some concepts that I think are going to help. We'll play with a little bit with some slides from the principles book to help refresh some of the anatomy and those kind of things, and then take it into some really cool content, some research that I pulled up for you, and be able to look and see like what is the deal with the frequency of neck and shoulder pathology in our population, especially over 50, and what is the relationship with the thoracic spine. I hope to make some really good ties that make sense to you today. So let's jump in, and just to sort of get us in the right frame of mind, one of the things that I want us to think about is how do we look at our clients that are suffering particularly from neck and from shoulder problems and pathologies. And if you think of the main pathologies that we see orthopedically, they come down to lumbar spine, cervical spine, shoulders, and knees. Those are the biggies that we see in the community. And over 50, we see it's almost an expectation that men and women over the age of 50% of them are going to be dealing with shoulder girdle problems and rotator cuff tears, and pretty much everybody's going to be dealing with cervical degeneration. And the point that I want to set the framework for now is in the concept of distribution of movement equals distribution of force. Where are the alternative movement locations in the human body that could decrease the amount of stress going through the neck, the shoulders, and the low back? And what that shows us is that this big structure right in the middle of the neck and the low back, called the thoracic cage, has incredible capacity to move, and it has incredible capacity to distribute motion and maintain proper dynamic alignment of the facets of the neck and the lumbar spine, maintaining dynamic alignment of the shoulder girdle. And that's what I hope to show you today, so that before you jump on the bandwagon of wanting to go treat a shoulder problem or a neck problem, and you're asking me questions all the time, how do I treat the neck? And how do I do that with Pilates? And how do I make that work? It becomes very difficult. We look at this first principle of movement in Polestar. We have a lot of education and learning about the thoracic cage. And this is, if we understand this and we understand how breath plays into it, then we're more likely to understand how it can actually distribute some of the movement for us. So as we look at this slide here, what we see is a very flexible protection of the vital organs. You've heard me talk about the fact that in the front of the spine, the front of the rib cage, we have a floating bone called the sternum and the manubrium, and cartilage connects it to 12 flexible bones called the ribs on each side. And then we look on the back side, what we see is 12 articulating facets, and vertebra, disc. All of these are motion sensitive. All of them move a lot or have the ability to move. Now, one of the things we're going to be looking at today is that because of our westernization and sedentary lives, we have been sacrificing the benefit of the thoracic spine as it relates to dynamic alignment and dynamic mobility of the surrounding joints, meaning the cervical spine, the shoulders, the lumbar spine, and we could even look down the kinetic chain and see its relationship to everything. When we look at some key factors in this anatomy, we look at the diaphragm. And the diaphragm itself is connecting itself to the ribs. We look at the diagonal of it. It can connect from T4 in the back. T4 is the dome, T7 in the back, T7 in the front, and down on the ankles, you can see it being as low as T12. And so this diaphragm sits in there, and I'll show you a little better picture of it. We look from the underside, it sits inside the rib cage, and it can narrow and expand the rib cage in its contraction to expand and release the lungs. And so that's something that's going on all the time in our breath. And a lot of times you'll notice that if you're not getting your patients or clients to breathe and have actual ribs moving with breath, then you're probably just doing belly breath or accessory breath, which really doesn't facilitate any mobility of that thoracic spine. And that's going to be our goal today, is to understand how do we get movement in that thoracic spine. When we look at what's called the infra-abdominal pressure or the hydraulic amplifier, again, we're looking at these dynamic, spontaneous relationships around the spine that are able to distribute movement, distribute force, distribute stiffness as needed based on the load. So if I create too much stiffness and it doesn't allow movement of the thoracic cage or the lumbar spine because I'm volitionally trying to contract those muscles, go ahead and try that right now. Just contract your abdominal, pull that belly in, lift the pelvic floor up. That's an unnecessary amount of energy that is creating stiffness that actually interferes with normal movement distribution. Now, if I was lifting 400 pounds in a deadlift, which I would never do for myself, but if I was, I would want as much intra-abdominal pressure as possible. So I would have to put a belt on and have to wrap my knees and pray that I don't destroy my body doing that lift, right? I'm not going to spend too much time in the musculature of this area, and I want to jump in more of looking at some of the dynamics of movement and the biomechanics in here, and realizing that if you can just sort of look at the relations, these are the posterior serratus, inferior and superior. They open things up like an accordion. So if they're working well, they can stabilize for breath expansion, or they can cause that breath expansion. In Pilates, when we teach breathing into the back, like we're doing the hundreds, and we say inhale into your back or inhale into the floor. These are the muscles actually that are activating when you do that to create that expansion, or that image of a cell expanding on a cell load. That's what's actually happening. In this one, we're actually looking at the sternocleidomastoid and the accessory breathing muscles, the scalenii, and how they actually lift the top ribs up to be able to increase a little bit of air. It's called accessory breathing for a purpose. However, this is really important when we talk about shoulder girdle. If we want the shoulder girdle to be stable and mobile, and when somebody's over-recruiting the muscles in their neck, they're actually pulling the shoulder girdle forward and closing the anterior space. You can sort of think, the best way of thinking of accessory breathing is thinking of smoking a cigarette, right? You go, and you'd see the tightness here in the front. You'd see the head protrude forward. That's going to cause the shoulders to round. So if you look at chronic smokers, you see a very closed anterior chain of the myofascial tissue, right? So it's, if I took my tensegrity model, it would be closing the front of it, closing it together, right? So there's really too much compression there, and that's not going to allow the shoulder girdle to move, which I'll explain in a little bit. So you're just giving you some foundations of things. I'm not going to go into too much pelvic floor or physiology. I want to jump here into the connective tissue. Now, when we look at the connective tissue, remember everything that we often refer to as inert structures really is very much alive. It's very integrated with the fascia. The fascia is touching every cell, going into the nuclei of every cell, and they all have a communication in them. So you can think of this fascia connecting the cartilage to the sternum, and that same fascia connecting through the cartilage to the rib, and then through the ribs around to covering the bone of the rib is the periosteum, and then coming into the disc in the back, and the vertebra, and the facets, and the transverse process, all being connected with these connective tissues, fascia, ligaments, and articulating cartilage. And all of that being that, again, and that's why I brought the tensegrity model with me today, all of it being that there's this like dynamic movement happening in all directions and all planes that is really dependent upon compression and tension. And that compression and tension in the thoracic cage is what I am going to propose today to you is the way to treat cervical, shoulder, and low back problems that we'll be talking about. So now you could imagine if all my fascial chains are really compressed in front and the tension's too much in back, then the shoulder girdles, and you could feel it. Like if you just slouch down, you might be slouching down now as I'm talking, lift your arms up as high as you can, right? And now lift the chest back up and lift your arms up as high as you can. And all of a sudden, the shoulder girdle has a lot more range of motion just based on the simple position of extending and opening that thoracic cage. So these tissues become very important. I treat a lot of patients that have costochondritis, they have inflammation of these tissues, probably because they don't have enough movement in other places in their thoracic spine, and they're trying to do some new yoga moves or some new Pilates moves, or they're golfing and they haven't done that kind of movement, and they create a little bit of shear force around those tissues and they get inflamed. And so we go back, instead of just treating that tissue that was inflamed, maybe it's more important for us to look at that whole thoracic cage and see if we can add 2 or 3 more segments of movement strategy could be enough to completely diffuse the irritation to that tissue. Let's take a look now at the actual joint itself in the back, where the rib comes into. I'm going to use a little laser pointer to help us here. But if you look at this area right here, this is the head of the rib. And the head of the rib is going to come in and it's going to articulate with the intervertebral disc, right? That's it. Just think of it as it's connecting to the intervertebral disc. And then it has a little facet above and a little facet below. Facet just means an articulation surface for the head. So the head is in there between the 2 vertebrae, equally displaced between the superior and inferior vertebra. The other important thing we see over here, and that is the neck of that rib is actually articulating with the transverse process of the vertebra below. And I don't know why we don't talk about this more in our manual therapy courses, in the literature. I'm going to show you some literature in a minute, that we don't talk about the properties of movement in the thoracic cage and how crucial this movement is in preventing some of these areas of dysfunction. We're now looking at the first rule of ribs. And the first rule of ribs says that where the disc goes, the rib goes. So that means that if I go into extension, right? So here, put your hands together. If you go into extension, the disc nucleus is going to transfer forward. The weight and the pressure transfer forward. It's like a little balloon in there. It's going to transfer anteriorly. Well, if the ribs are connected to that and the disc is moving forward, then the ribs are going to move forward as well. So you can experience that just in your chair. Going up in extension, you can imagine as those vertebrae go into extension, ribs are going to protrude forward. And likewise, if I go into flexion, the same thing's going to happen. The ribs are going to go back, following the rib to go back. Or if I go into side bending, the disc goes to my left. The ribs, both ribs go to my left. They're going to follow that nucleus pulposus inside that disc. Well, that helps us a lot because we can imagine now when I'm doing mermaid, and when I'm doing swan, and when I'm doing roll up, that I can imagine the rib cage now being very much a part of that articulation of the spine in those areas. And if I can add 2 or 3 more segments, I can make a significant dent in the perturbating forces or the irritating forces that are affecting the low back, the cervical spine, and the shoulder. So let's keep that in mind, right? Now we have another rule of ribs in Polestar, and that's the second rule of ribs. And remember how I said the rib attaches to the transverse process? Well, that transverse process is the transverse process of the vertebra below, right? So when I go into extension now, that rib is going to follow that transverse process of the vertebra below. So if I go into extension, the lower rib is going to tilt down in relationship to the superior rib. So now if I go into extension, rule 1 says rib's going to follow the disc. It's going to go anterior. And rule 2 says, because it's connected to that lower vertebra transverse process, the rib's going to open up like a slinky. So one rib's going to go down and one's going to go up. And that's going to create an opening. Now, I can't express this enough. When we're teaching our movement, If we're teaching an extension or flexion, and we have the whole rib cage moving as a unit, what ends up happening, unfortunately, is that all of the force is going to go into the cervical spine at 5, 6, 4, 5, or into the lumbar spine at L4, 5, L5, S1, right? So what does that look like? And you've seen it over and over again. Somebody going into swan, and all you see is the rib cage lifting up beautifully. The whole rib cage comes up, and a hinge happens in the low back. Right? Excessive flight extension in the low back, and really the whole rib cage just lifts up whole. It doesn't move. It's not dynamic with the movement. And the same thing with roll up. People roll up to T7, the base of their shoulder blades, and then they have to do a thrust to come up because the rib cage is not allowing that to move. So a simple way of thinking of it in this rule 2 is I'm going to do a roll up. I'm going to send the ribs back and up underneath my heart. And that's going to give me the mobility in those lower thoracic segments and make it easier for a person to roll up rather than having to thrust or to lift their legs off the ground, right? And by restoring that strategy of movement, we will decrease significantly the pain in the neck. Let me share a little story with you. Years ago, we did a research study in 1996 at Loyola Marymount down in Southern California. And we had a machine that was called the Metricom. Now, the Metricom measured distances or range of motions of the spine by looking at the spinous processes from the sacrum all the way up to T2. And we had the subjects bend over and over again until we got a standardized measurement. And what we found collectively was that the majority of the movement of flexion, bending forward, came from L4, 5, L5, S1. Where are the majority of low back injuries in Westerners? L4, 5, L5, S1. And we saw very little movement in the upper lumbar and nothing that we could measure in the thoracic. We then split the group randomly into 2 groups, a control group that went back and laid on a plinth table for 45 minutes, came back and measured exactly the same, and an experimental group that went and did their first time of doing a Pilates reformer class for 45 minutes. If I remember correctly, there were 5 exercises. We did footwork, bridging, seated roll down, feet and straps, and quadruped. I think those were our 5 exercises. And so afterwards, they came back and measured, and we had 3 significant outcomes that were completely changed the way that I looked at how Pilates decreases back pain and neck pain and shoulder pain. And what we found was that the overall range of motion of forward bending increased significantly, right? So significantly means statistically it was significant, which had to be enough. And you could easily justify it and say, well, you know, we had good increase and warm up of the hamstrings and the back muscles, so that makes sense. And we say, okay. The second finding was that there was increased mobility in the upper lumbar, and we found mobility in the thoracic. And you could think the same thing. You did bridging, you did seated roll downs. It would make sense that you would find this additional movement in the thoracic spine. But the third and the most important one was that L4, 5 and L5, S1 decreased their range of motion by 50%. I'll repeat that. By increasing a little bit of mobility in the strategy in one session of Pilates for 45 minutes, there was a 50% decrease in the movement and the forces or stresses in L4, 5, L5, S1. This was a gestalt for me. This was a light bulb going off and saying, Brent, it's not about trunk strength. It's not about core control. It's not about stabilizing a segment. We actually stabilize L4, 5, L5, S1 by increasing mobility in thoracic and upper lumbar. We reduce the stress by doing that. Well, I'm proposing to you that the same applies with the cervical and the shoulder. That if we're able to increase the mobility, we understand the biomechanics of that thoracic spine, and we create the strategic opening of that thoracic spine, the result of that is going to be a significant reduction in the stresses that are going to go through the neck and the cervical tissues and the shoulder tissues. So when we look at the nature again and where movement comes from, and I've always said this, if we understand the biomechanics of these tissues, then we know where the strategy should occur. I'll repeat that. If we know the biomechanics of these tissues, these structures, then we know how the strategy should be motivated, how we should be motivating our clients and patients to move in a more efficient and effective way. So here what we're looking at is the relationship between that rib, the neck of the rib, and the transverse process. So between T1 and T7, the way the rib articulates with that transverse process is round, right? It's almost like a ball and socket joint. You can see it right here. You see a roundness, and then you see a concavity. So convexity, concavity. And so that's going to create a motion that is rotatory, right? It's like the rib is rotating inside that joint. And so what that tells us is this is where some of that slinky opening of the front or the accordion opening of the front is going to occur. When we look down lower in the T8, 9, 10, we see more translatory structure. That means it's going to slide. And what that's going to do is going to create a lateral expansion, So out to the side. That would be in the coronal plane. Like when we go into mermaid and we're breathing into that opposite side of the side bend, we are expanding that, especially T8 to T10, accordion-like opening and closing. Now we have names for that we use in biomechanics, and we talk about the water pump handle. So if you grab your sternum and you open and close it, that's the water pump handle. That's going to be T1 to T7 with a rotation. So if I'm doing swan, or I'm doing roll up, or I'm doing an extension to dart exercise, I'm looking to be able to facilitate that extension also through that area there. Now, when I go lower, we call that bucket handle. That's going to be the T8 to T10. That's going to be the expansion in the coronal plane, in like an abduction plane, right? And so if we understand that, that helps us. Now, here's a little insight. The reality with these is this is the bias of a joint. This is the bias of the joint. It's not the rule of the joint necessarily, it's the bias. Meaning that if I want to do expansion into sagittal plane in my lower ribs, I can do that too. It's just that they're biased. The easiest way for them is going to be in a lateral excursion. And in the top one, it's going to be a sagittal excursion. So as we think of the movement that we want, we're going to talk a little bit about how the scapula sit on that thoracic spine. If I don't have good sagittal movement and play there, I can never get my scapula in the right position to maintain congruence with my humeral head. So the last slide here on the breathing part is looking at the relationships. You've heard me talk about tubes. This central tube is the spinal tube. It's a tube, imaginary tube around the spine. And then we have a tube that I have imaginary between the roundness of the head and the inside of the pelvis. And then the last one I have is outside of the rib cage, the lower rib cage, to the outside of the pelvis. Now, a good way of thinking of dynamic alignment as it pertains to these structures is that if they had fluid flowing through them, which they do, right? We're all water, 50%, 60% water. That fluid's running through those hoses or those tubes. If I lose that organization, let's say I hyperextend my neck, what I've done is I've kinked the spinal hose. If I flare the rib cage, I have kinked the rib cage to pelvis hose, and possibly if I do an excessive amount of movement, I've also kinked the head to pelvis, internal pelvis hose, as well as the spine hose, right, or tube. And so this is just a nice way of thinking when I'm using my eyes and I'm watching my clients move. Do I see the movement as these three hoses or tubes moving through space without kinks? How do we remove kinks? Distribution of movement. How do we distribute movement? Increase the number of segments that are participating in the strategy. How do we increase the number? We create movement opportunities and images that facilitate our patients and clients to explore segmental movement. That's why the segmental piece is so important. When I have novices coming in and I say, let's watch one of our fellow comrades here doing bridge, and they're doing their bridge and we're counting how many segments do you think they're moving from? Now, if I was to do a fluoroscopy, I could tell you that they probably were moving from 1 or 2 segments. But the people watching are going 12, 10, right? Because they don't understand what 1 or 2 segment look like. So we have to train ourselves of what that looks like. So then we do something like a bridge with lateral translation, drop down 1/2 inch, same thing, and repeat it, repeat it, repeat it. We're likely to add 2 or 3 more or additional segments in the movement strategy. Now they do their bridge again. All of a sudden, it's like, oh, I see movement now in this area, in this area, in this area now. I'm counting 4 or 5 segments. Still might be a little high, but it's better than I'm thinking that it's 12. So we have to have that experience of really looking at this idea of distribution of movement equals distribution of force. I can increase that distribution by increasing segmental movement. I can increase segmental movement by creating the proper images and strategies for my patients and my clients. Okay, I hope that sticks a little bit, because we're going to jump into mobility now, which is just as important, if not more, is looking at how does the principle of mobility, this idea of distribution of movement equals distribution of force, play in our direction of movement. Of course, we have to understand our planes of movement. I think it's important whenever I talk about mobility that we understand the sagittal plane splits us in half. This is the sagittal plane here. So it's like a left and right side. We have the coronal plane that splits us into front and back. And then we have the horizontal plane that splits us into top and bottom. So when I talk about these planes of movement and where do we need to increase the planes to get proper shoulder and cervical movement, it'll make more sense. So let's look at a dynamic movement here of a golfer and thinking of, here's a beautiful example of how this is a supple thoracic. Yeah, you can see how beautiful that is. He has the extension and the rotation coming there, which we'll talk about in a second. He doesn't have a whole lot of rotation happening in his lumbar spine, which is correct. He has good rotation happening in his hip, his knee, and his ankle. And so here is a beautiful depiction of distribution of movement equals distribution of force. Where should spinal rotation occur? Spinal rotation should occur more in the thoracic spine because of the nature of those vertebrae. Let's take a look at those vertebrae. So here, if we look at the 3 type of vertebra segments that we have the lumbar. And if you hold your hands up with me and just put them like this, so the hands are vertical, and we'd call this a sagittal plane, right? So they're like this. And so the facets gliding on each other, superior and inferior, they're going to provide movement of flexion and extension. You can imagine them gliding on each other. They can also, if it's unilateral, they can do side bending, lateral bending in the coronal plane. But because they're sagittal and close together, they're not going to have a lot of rotation. So it's not normal to have rotation in the lumbar spine. As soon as we come up in the thoracic spine, put your hands like this now, our vertebrae are now 65 degrees in the coronal plane. And now in the coronal plane, we still have flexion extension, but now our unilateral movement results in rotation. And we can get a little bit of side bending as we bump the ribs or bump the facets, but it really is flexion extension and rotation. Lumbar is flexion extension and side bend, right? So if we can keep that in mind, we know where that's happening. Now let's work up the spine into the upper thoracic and the cervical spine. So thoracic, we said, is at 65 degrees, cervical is at 45 degrees. And the base of the head is 0 degrees. So we have the ability, the cervical spine's job is to provide the mobility for the head to use its senses of seeing, hearing, smelling, feeling, right? And so it's where we have to have the greatest amount of movement in different directions, looking up, looking down. That's going to come from extension, flexion. We got the rotation, which 45 degrees gives us more rotation. However, if at the lower cervical and upper thoracic vertebra are not moving, then we're going to have an excessive amount of movement happening at C4-5 and C5-6. Where do the majority of cervical injuries and degeneration occur? That's right, C4-5 and C5-6. Can you imagine if our attempt to look up included some extension in the upper thoracic? It would increase our range of motion and decrease the mobility segmentally of C4-5 and C5-6, just like we demonstrated with the low back. Just like that. And if our rotation is about having thoracic, you know this when we do spine twist, we don't want the arms doing the twist. We want the thoracic spine doing the twist. We keep the sit bones planted so the lumbar spine stays stable. It's not going to get much rotation, maybe 3 to 4 degrees per segment, right? There's a problem we have. If that thoracic spine doesn't rotate, same thing happens. We rotate the cervical too much, right? And we start hurting the C2, C1 vertebra, C2, C3, 4, 5, 5, 6, and we hurt the low back. So if you think of that picture, that nice picture of that golfer, imagine now if he was in a rounded back position doing the golf, now that rotation force is going to come from his knees, his low back, his shoulders, and his neck. But if we added 4 or 5 segments in that thoracic spine extension, that would remove like 80% of the stress in the shoulders, the neck, and the low back and the knees. We have to start thinking this way, is like what makes Pilates so freaking powerful is that we're facilitating breath and thoracic mobility. We don't even know it, but that's what we're doing. And when we facilitate these mobility directions and then we apply them to functional activities, all of a sudden their golf game gets better, their pickleball game gets better, the risk of their shoulder problem gets less. The diagnoses that they have of degenerative cervical spine don't really mean anything. They just mean that we're getting old. They don't mean that the head doesn't work and the neck doesn't work anymore. Now, there's a really special vertebra. You've heard me talk about this before, T12. T12 is the place that's very unique in humans. We don't see this in the primate. We don't see it in four-legged animals. It's out at T12. And if we look down at the lower facet, it is a lumbar sagittal facet. And if we look up at the superior facet or zygapophyseal joint, we see a thoracic facet in the coronal plane, right? So this is where transition and reciprocal motion takes place. So as humans, when we walk, there should be this rotation happening reciprocally in our upper and lower body. If the thoracic spine isn't working and we're having these walking and running forces, we're going to feel excessive force in the lumbar spine because it's going to have the side bending component to it with every step. And where does the rotation go? What's going to come from the shoulders or it's going to come from the head and neck? Where if we had good distribution, and when I teach a course, sometimes I'll pick up somebody's leg and their foot and I'll shake and oscillate their leg and try to see how that communicates up through the whole spine. Is there a communication where, the hip is talking to the pelvis and the pelvis to the sacrum and the sacrum to the lumbar, and then it starts to transition, it hits T12, and all of a sudden it converts into a rotation in the opposite side, and I see the shoulder on the other side oscillating and the head rotating in the direction. If I can see that oscillation communicating through all of the joints, I know that these people are going to minimize the risk of injury with ground reaction forces or with swings or swimming or golfing kind of actions and even lifting kind of activities. Very powerful. When we look at the lower extremity, again, we get some really cool stuff, right? This is looking at the accessory joint mobility, right? We've talked about arthrokinematics versus osteokinematics. Osteokinematics is what we talk about, flexion, extension. It's the bones moving through space. Where the arthrokinematics is looking at the actual movement inside the joint. And the movement inside the joint always has to move in opposite direction. I'm not going to go into too much detail on it today. We'll save that for a knee and hip and foot lecture in the future. But the thing to remember is that when we're looking at rotatory activities, which were made rotate, where we are rotational animals, right? Any movement in any joint, the two bones have to move in opposite directions for movement to happen there. Now, when I was reading a textbook the other day, I won't say whose book it was, but it was a thoracic spine book and thoracic rib cage, very well accepted author, did not realize the arthrokinematics of the ribs and the vertebra. That if the vertebra is moving up, the rib's moving down. That there's this arthrokinematic relationship. We talked about it in our cueing in Pilates of where we have, the ribs opening up like an accordion or like a fan or like a slinky or moving through space. For that to happen, vertebra move in one direction, rib move in another direction is what allows that motion. That's really, really important. So a key thing to remember, especially in the extremities, is that if I want external rotation of my femur, that means I need to have relatively an internal rotation moment of my pelvis and an internal rotation moment inside of my tibia. And we'll save a deep dive for that for another day, because I want to jump into the shoulder girdle. So how is, this is our key point now, the last 20 minutes, I want to jump into this. How is the thoracic an influencer of shoulder and neck injuries? How does that happen? So we know, and I'm going to show you a couple studies, that the incidence of shoulder pathology in aging adult is ridiculous. And we just accept it in the medical community. We say everybody over 50, we expect you, if you're active, you're going to have shoulder girdle problems and rotator cuff tears. We also look at the incidence of degeneration cervical spine, and we see that also being up in the 60 to 80% over the age of 50, which is crazy of thinking that frequency. So when we think of a rotator cuff tear, I'm just going to pick two pathologies today. The rotator cuff tear in the shoulder. So what we're looking at here is, here's the acromion. This is the supraspinatus tendon, but it could be any of the rotator cuff tendons. It could be infraspinatus, supraspinatus, teres minor, it could be the subscapularis, any of the rotator cuff tendons could tear. And this is what a tear looks like. Now, a tear can happen from an abrupt movement of the humerus against the acromion, or it can happen from wear and tear because we've lost congruence. So you can imagine if the humerus is a little out of congruence, it's rubbing on every time you lift your arm up, every time you pick something up or reach overhead, you're rubbing that acromion on that tendon. This is the more common cause of rotator cuff abrasions and injuries, inflammations. And so what we're looking to do is, how do we, let's say we already have a little bit of abrasion in there, let's say we already have a little bit of a tear. How do we get the head of the humerus back into a congruent state and depressed underneath that acromion so we stop irritating that rotator cuff? Now, if it's red and inflamed like this, what that means is it's trying to heal. And it can't heal if we keep exacerbating it, if we keep perturbing it, if we keep stretching it and rubbing it against there, or keep lifting our arms when the shoulder blade is stuck forward because the thoracic stuck forward. All we're going to do is keep irritating that rotator cuff. So we're going to look at that one. The other one I wanted to show you a picture of is degenerative cervical spine problem. So here we see, this is the spinal cord coming down from the brain. The white stuff is the cerebral spinal fluid around it inside of the dura. This is like a slice down the middle of the cervical spine and then turns sideways to give you your orientation of it. And what we're seeing are the vertebral vertebrae and disc are here in front. And you can see how some of the disc have protruded into the spinal cord. And you can also see the degeneration of the zygapophyseal joints or facet joints that, because of excessive extension there and movement there, are now hypertrophying or scarring also into that central cord. Now, if we see this, we could also hypothesize that the nerve roots are also being compromised by those facets, that hypertrophy of those facets. So this is where, looking at these degenerative changes, we have to be aware of, like, why is there so much stress going through those areas and not the others, right? If we come down to thoracic, look how much space there is here. Look how pristine this is. Well, it's because there's no movement happening. I'll repeat that. If it looks like this, it's because there's no movement happening there. Well, that's not healthy either. These joints need movement to be healthy. We need to be able to move them. Let's take a look at some research before I answer some questions here. So here, an epidemiological study looking at the natural history of rotator cuff problems, and it says that the etiology of rotator cuff disease is likely multifactorial, including age, right? Age-related degeneration and microtrauma and macrotraumas. The incidence of rotator cuff tears increases with age, with more than half of the individuals in their 80s having a rotator cuff tear. Now let's ask the question. Are they getting the rotator cuff tears because they're 70 years old? Or are they getting the rotator cuff tears because years of not having good distribution of movement have continued to wear down that rotator cuff tendon I was showing you over the years to the point that it no longer is repairable, right? We know that the older we are, the harder it is to repair. Big problem. So just keep that in mind, that we have to ask ourselves, this is the finding, but it's not talking about the cause. It's just saying old people are going to, 50% are going to have rotator cuff tears. And then it's multi-factorial. Well, the biggest factor in my mind is that if you don't have distribution of movement, you're not going to have distribution of force, you're not going to have dynamic alignment, you're not going to have congruence, you're going to wear down that. And because we're bipedal animals and we like to do things overhead, we like to reach, we like to play pickleball, we like to put our luggage up over our heads, we like to have closets with things that are up there, so we store things. We're always lifting our hands over our head, or we're putting seat belts on every day. Well, those are motions that tend to compromise that tissue if there is not motion in those segments. Very important. All right, let's take a look at another study. This one said the natural history of non-operative treated symptomatic rotator cuff tears in patients 60 years or younger. Conclusion: full thickness rotator cuff tears tend to increase in size in about half of patients aged 60 years or younger. Surgery should be initiated considering in these patients to prevent a probable increase in size tear. Now, this is interesting. Patients treated non-operatively should be routinely monitored for tear size increase, especially if they remain symptomatic. So what they're saying is that, this progression of the tears, they're associating with age. They're not associating with activity, behavior, or strategy. This is a major mistake in orthopedic medicine. Major mistake. We're making assumptions that everybody's going to need knee replacement. 50% of the people are going to need shoulder surgery. People that are active over the age of 60 that lift weights or exercise are going to have a rotator cuff tear because of their age and their activity. That's a false assumption. That's not considering if we took another population and we had them all doing Pilates and really working on thoracic mobility to play pickleball and overhead sports, we would find that population, if we took them at the age of 30 on, that we would not have the same incidence of rotator cuff tears or size of tears or degenerated tears over time. We just wouldn't see it. Rotator cuff tears in overhead athletes. Full thickness tears, however, have fared much more poorly in overhead activities. These overhead athletes. Why? Because they keep pinching the tendon. So even if they do the surgery on it, here it's saying the surgical options are not as successful in populations that are doing overhead sports. I'm going to show you in a minute how we avoid having the impingement with overhead sport. That it's not, age has, the problem with age is that tissue adaptation and healing slows down. That's the real challenge with age. And I see a question just popped up by Christine about menopause concerning rotator cuff tears. Menopause ages a woman pretty quickly in many ways. Heart health ages pretty quickly. Bone health deteriorates pretty quickly if those hormones are not present in the body. Likewise, connective tissues have some of the same aging properties, like you age very fast in those next 10 years after menopause. It still is that if the body is functioning well and has good alignment, then we're not worried about the trauma to the tissue because we're not going to traumatize the tissue. But if we keep making the exception and saying that everybody that plays sports, but they have a rounded thoracic spine because that's what we look like, or in the gym, walk in the gym, go look at everybody with a rounded thoracic spine, they got their rounded chest and they got their big deltoids in the front, and their pecs, and you look at their back, and they're missing all of that tension in the back. They're just compressed in the front. You want to lift a shoulder up when you're compressed. We already did that. You can't get the shoulder up. So now when I lift it up, I'm either going to hurt my shoulder or hurt my low back or hurt my neck. Those are the three areas that are going to compensate for lack of thoracic mobility when it's compromised. Kinematic of the cervical spine under healthy and degenerative conditions, right? This is a systematic review. And what they found was that the progression of degeneration restrains mobility, right? Which seems to be maintained or compensated by adjacent non-affected segments. Where are the adjacent non-affected segments? Well, I'm talking about the lower thoracic and upper thoracic spine. If they don't move, there is too much movement in the C4-5, C5-6, and that's where we're going to see the degeneration. If we have a distribution of force, we will see less. Degeneration is normal. I don't want to make it abnormal. It's like a wrinkle. But when we have all forces transferring through 2 or 3 segments, and we're doing some kind of great physical activity, we're going to see problems in those areas. Okay? And let's now, I'm going to take us into just a video that I want to share with you. So now let's take a look at this relationship, right? So we see that in order for the arm to come up into abduction, right, that scapula has to be able to slide and glide across the rib cage. Now, this depiction from primal anatomy shows the rib cage is static, but now I want you to think of it actually moving and dynamically gliding through space and being able to work harmoniously with that scapula moving in its direction. And I love I could watch these things for hours, especially this one here overhead. Here's overhead activity, right? Clavicle has to spin and rotate up and over. Well, if your pecs are tight and you're rounded, that's not going to happen. And if your thoracic is in flexion, you're also not going to get that motion. So this one's looking at flexion and extension, again, looking from 4 different angles. I just love watching these things, and so I'll try not to be too distracted on it because I love looking at the flow and the relationship that has to happen where that scapula and clavicle, their primary job is to maintain a relationship with the humerus, right? So here's my tiny little bone set, but they have to maintain that relationship. Wherever the humerus is going, the scapula and the clavicle have to move around to maintain that congruency. If the rib cage is restricted that it cannot allow the clavicle and the scapula to move, then we're going to end up with shoulder girdle impingement, right? If the thoracic, upper thoracic is not moving, then we're going to have an excessive amount of force in the cervical spine, and we'll see degeneration there more rapidly. Those are the 2 key things that we're taking away today. So if we think of, and I'll pick up a little bigger scapula here, I want you to imagine, you can also like grab your phone and do this drill with me, but I want you to think of the scapula. So hold the scapula up. And in this position, I want you to think of raising the arm up into extension. So we know that this scapula has to be able to go into elevation, depression, protraction, retraction, right? Upward rotation and downward rotation, right? What it doesn't do is extension and rotation. I'll repeat that, right? Let's play the game. So this is my right, it's actually my right scapula, sorry. But going up in elevation, depression, protraction, retraction, upward rotation, downward rotation. It does not, it is my left one, sorry. It does not go into extension or horizontal rotation. So what does that mean? What that means is that in order for us to go in an overhead spike, like in volleyball or tennis or reaching overhead, that the thoracic spine has to be able to go into extension and rotation to support that scapula that is actually supporting the shoulder, right? So that's the message I want you to take home today, that has to happen in order for us to make that work. I see that my battery's running low, so I'm going to answer some questions for you. Diane Rose said, should a side sleeper stay off a rotator cuff injury of 12-year-old? You know, shoulders are the most uncomfortable and painful thing in our bodies. So, and most importantly, they're painful at night. So you got to find pillows and ways of sleeping to support it while it's healing. Sometimes the injuries are so bad they do need to have surgery to be able to make them right. But yes, it's a matter of being comfortable and be able to sleep to get the healing. And if you can't sleep because you're uncomfortable, you got to find another way to do it. Lisa Hines said, I have an elderly client, kind of frail, osteoporotic, has neck and shoulder pain. I understand the importance of thoracic mobilization. What strategy can I use in flexion if flexion is contraindicated? They're already in flexion, and extension is not contraindicated for osteoporosis. This is some of Sherry Bett's work. Like we need to work on getting extension, laying on the spine fitter balls, right? The two trainer balls, like getting them to start getting segmental extension that'll give them a little more uprightness and take some of that load away from their neck and their shoulders. Nell Remit says, I have a background in science and I'm curious to know how rigorous the peer review process is for sport-related journals. Could you explain how thorough the review process typically is in this field?
The bottom line is that all research is statistics in, statistics out. And we know that not all statistics are great and that the isolation of those groups are difficult. But the research that I was pulling from are pretty well respected, and I could pull out a lot more research on these systematic reviews. So when we see systematic reviews, it's really looking at a lot of different peer-reviewed articles. It's using the Pedro score to see if they're legitimate or not in the way that they're designed. And that in and of itself gives us the idea that it's a better quality research and outcomes. But all research is subject to interpretation. And so I would just caution you that we look at these things that are able to tell us, is this a problem or not a problem? Now, right now, I would propose that if you're interested in research, could you look at the relationship between thoracic and cervical spine? Could you look at the relationship between thoracic mobility and shoulder girdle mobility, especially in extreme overhead activities? Polestar Pilates Hour, bringing you the world alignment of physical, emotional, and spiritual. And that above all things, be kind and have a blessed weekend. We'll see you next week. Thank you so much.